Assalamualaikum viewers and welcome back to my channel Denver's Hub. Today in the playlist of oral and maxillofacial surgery we will be discussing the same prevention and management of extraction complication. In that regard our today's video will be about the Oro Antral Communication and Fistula. So in this video we will be studying the diagnosis and confirmation and the management of Oro Antral Communication or Oro Antral Fistula. So now let us study about the diagnosis and confirmation. So if there is a large Oro Antral Fistula or a small Oro Antral Fistula, or that in case is an Oro Antral Communication. So how you are going to diagnose or confirm the condition. So first of all, let us study it for the small Oro Antral Fistula or in that case Oro Antral Communication. First of all, you will also perform a nasal blowing test that is known as the Valsalva maneuver. In that, we will close and compress the nostril of the patient, and then we will ask the patient to blow through the nose. The bubbling of the blood in the socket will occur, and it will occur because there is a communication between the nasal cavity and the antral cavity. So when the nostrils they were closed and compressed, now if the patient was blowing through the nose, the air it was usually escaped into the oral cavity through the antral cavity, and the bubbling of the blood in the socket is seen. So this also confirms that there is a presence of any oroantral communication and opening. Secondly, that you can also perform the cotton wisp test, and that the cotton it is placed at the oroantral communication or fistula region, and then the patient is asked to blow through the nose. And in that regard, the cotton will usually displaced out because again there was a communication present between the antral cavity and the oral cavity. When the patient blew through the nose, the air entered from the nose through the ostium into the antral cavity, and from the antral cavity by the communication into the oral cavity, and it usually displaces the cotton. Secondly, the cotton wisp test was performed and it also confirmed it. You can also perform another test, that is the mouth mirror fogging test. In that test, the mouth mirror it is usually placed at the oroantral fistula communication region. Then again the same process of blowing through the nose. The air escaped through the ostium into the maxillary sinus, and then from the sinus through the communication and opening into the oral cavity, and then usually due to the escaping of the air into the oral cavity, the fogging of mouth mirror occur. So it also confirms that there is presence of any oroantral communication. So these were the three important steps that can be used in the diagnosis of the small oroantral fistula and or the oroantral communication. Now we will be discussing about the diagnosis and confirmation of the large oroantral fistula. It can be easily detected by inspection as the opening is quite large. Further, you can do any investigation as well. You can do the intraoral periapical radiographs, you can do the OPGs as well, CT scans or PNS view. In the PNS view, you will see the fluid level in the PNS view that will be diagnosis of the maxillary sinusitis as well. For further investigation and defect size and lining situation, you can also go for other investigations. After the diagnosis and confirmation, now we will be studying out the management of the oroantral communication first. So it is basically determined on the basis of the size of the opening. For example, if the opening is just 2 mm, in that case the blood clot it will be formed, it will organize and heal, and the opening will be closed off. So in that regard, you just have to ask the patient to take the normal sinus precaution. And if the opening it is 2 to 6 mm, in that case we need to place a gelatin sponge that will be forming the blood clot. Also we need to place a figure of 8 suture around the socket and an external pressure pack, and patient is asked to take the sinus precaution. We will be also prescribing the antibiotics and nasal decongestion. So now let us understand about the nasal decongestants. So as we know that in case of the oroantral communication or fistula, there was the nasal congestion that was occurred due to the inflammation around the ostium, and in that case the patency of the ostium could not be maintained and it affected the normal sinus drainage. So when we will be giving the nasal decongestants, it will maintain the ostium patency by resolving the inflammation around it, and after that it will allow the normal sinus drainage, which will decrease the chance of sinusitis and infection. So this was the mechanism of action of the nasal decongestants. Now if the opening, that is the oro antral communication, it is the 7 mm, so in that case we will be closing it with the flaps, and in that regard you could be using the buccal advancement flap or the palatal rotational flaps, and the rest is same. Need to advise the patient to take the medications, the antibiotic, nasal decongestion, and also to take the sinus precaution. So this was all about the management of oro antral communication. Now we will be discussing about the management of oro antral fistula. So as the fistula, it is a very large opening. It could be closed with the flaps. The only sole option is to close the opening with the flaps, or either with the bone grafts, or either with the alloplastic material. So first let us discuss the soft tissue flaps. In that regard, we have the local flaps and distant flaps. The local flaps include the buccal advancement flap, the palatal rotational flap, or combination of both, or we can also use the buccal fat pad for the closure of the opening. The distance flap includes the tongue flap, the temporalis, and the nasal septal flap. So these were the soft tissue flaps option that could be used to close the oro antral fistula. After that, we could also use the bone grafts to close the oro antral fistula. Bone grafts could be from the intraoral or extraoral sources. The intraoral sources include the chin, the retromolar pad area, and the zygoma. In case of extraoral sources, we could take the bone grafts from the iliac crust. Now we can also close the oro antral fistula with the alloplastic materials that include the hydroxyapatite, the collagen membrane, the gold foil or plate, or the aluminum foil. So these were some options that could be used in the closure of the oro antral fistula. We also have some other options as well, that is the plasma rich fibrin, the tooth autotransplantation, the guided tissue regeneration, the intraseptal alveoloplasty, and the immediate implant placement. So these were some other options available in the management of the oro antral fistula. So we also have some certain guidelines in that. First of all, it will be dictated upon the size of the communication. If the size of the communication it is very small, you could close it with the buccal flap, the palatal rotational flap, the buccal fat pad, or the alloplastic material. But if the size of the fistula or communication it is very large, anteriorly based palatal flap, tongue flap, or bone grafts can be used. Second guiding factor is the time of diagnosis. If the patient reported within 24 hours, the immediate closure can occur. It is after the 24 hours to defer the treatment first to treat the infection. Third important guiding factor is the location. If it is present in the anterior, that is the premolar, first molar, or second molar, the buccal flap or the palatal rotational flap can be used. But it is located more posteriorly, that is the third molar tuberosity region, you could use the buccal fat pad, anterior based palatal flap, or tongue flap. Last important guiding factor, it is the presence of infection. If there is any infection present, you should defer the treatment until the infection subsides. Or if there is no infection present, you can go on with the immediate closure. So this was about the management of oro antral fistula. So now we will be discussing the flaps and the techniques in a bit detail. So first of all, let us study the buccal advancement flap that was given by the von Reimann or Moxars. So in that procedure, we need to give the patient the local anesthesia or the general anesthesia depending upon the situation. Then we need to excise the fistulous tract, and after the excision of the fistulous tract, we need to make two buccally divergent incisions. After that, the mucoperiosteal flap reflection is done. Now the horizontal releasing incision at the depth of vestibules are also given to aid in the advancement of the flap without tension. And this was a modification that was added by the Burgers. After that, we will advance the flap and place it over the defect, and after that we will suture it. So this was all about the buccal advancement flap. Now the palatal rotational flaps. It is basically based on the blood supply to the flap. So it could be of two types. We would have the posteriorly based palatal rotational flaps, or we could have the anteriorly based. In posteriorly based, the blood supply is from the greater palatine artery, and this technique was given by the Ashley, in which first of all you need to locate the greater palatine foramen and then mark it. After that, make a safe incision, and then the mucoperiosteal flap reflection. Rotate the flap posteriorly into the defect area. While rotating it, there could be given a bend, a V-shaped excision of this bend that you can see also in the diagram that is being shaded in the green color. So here this was a modification that was given by the Kruger. And after that you need to place it on the defect and then suture it. So this was about the posteriorly based flap that utilizes the mucosa from anterior hard palate, that is unyielding. Remember that. Now we will be discussing the anteriorly based ones. Anteriorly based one, they uses the thicker mucoperiosteum mucosa from the posterior hard palate, that is yielding one. As the blood supply source is concerned, it is from the nasopalatine artery and of the same side and of the other side as well. So in case of large defect or maxillary tuberosity defect, you can use this one. So the process, it is same. You need to locate it and mark it the site, and after that you need to make the incisions and reflect the mucoperiosteal flap, and then you have to place it over the defect and suture it. You need to be cautious that greater palatine artery, it is cauterized at the greater palatine foramen to stop bleeding out there. So this was all about the rotational flaps. Now we will also be studying some supportive measures that are being taken after the closure of the defect. You need to prescribe the antibiotics, the analgesics, the nasal decongestants, the mucolytic agents, the steam inhalation, the antral lavage, and intranasal enterostomy as indicated. So these were some supportive measures along with the definitive treatment. So let us study a bit about the buccal fat pad that was used in the closure of the Oro Antral Fistula. The buccal fat pad, it has body and four processes. The four processes, they are as follow: the pterygoid, the buccal, the pterygopalatine, and the superficial and deep temporal. In children, this buccal fat pad, it gives fullness to the cheek, but the size, it usually regresses as the individual it grows. It has also got the supply from the three arteries, that is the superficial temporal artery, the maxillary artery, and the facial artery. So it is a very good tissue to use in the reconstruction of the oral defects. Remember that if it comes in the question, or if someone asks you that why it is very good tissue to use in the reconstruction of oral defects, so you need to give these reasons, that it has a very rich vascular supply from three arteries. Now let us study the procedure in a bit detail. So again, you need to give the local anesthesia or general anesthesia, then you have to make the incision with the buccal, and you have to reflect the buccal flap, go supraperiosteally into the cheek to retract the buccal fat pad with the periosteal elevator, and then make it and cover it the defect with the buccal fat pad. And after covering of the defect with the buccal fat pad, you need to place on the sutures. But important point to remember here is that the buccal fat pad, it is not covered, it is left uncovered, because here the epithelialization will occur within 2 to 3 weeks, and it will usually form the normal mucosa over it. Buccal fat pad, it is usually used in coverage in the third molar region or the tuberosity area, the defects located in that region that can be closed by the buccal fat pad. So this was all about the Oro Antral Communication and Fistula, their management, diagnosis, confirmation, and the clinical features. I hope this video will be helpful for you all. Don't forget to subscribe to our channel for more videos and updates. Thank you.